Thank you, Selena. Welcome, everybody. I'm Sarah Singer. I'm a professor of medicine and primary care and population health and a courtesy professor in organizational behavior at the Business School. It is my pleasure to welcome you to the third Stanford Center for Improvement lecture series lecture. I know many of you are affiliated, and that's wonderful. For those who are less familiar with the Center for Improvement, I think of it as a resource for improvers at Stanford and beyond. This lecture series is one of its programs, and if you are not yet affiliated but interested, or if you know of others who might be interested, please affiliate. We welcome all comers. I want to just frame up the discussion today by just saying very simply that between innovation and improvement is implementation, right? So innovation is the thing that tends to get the glory, but implementation is really the thing where the rubber meets the road. It's where change lives or dies. So it's really important. It's critical for us to understand how to implement an innovation or an intervention so that it takes root and so that it thrives and expands. In general, this is really very tricky to do because while there are many similarities across and within organizations, many aspects also differ greatly. So we need to understand how to do implementation well. And our discussion today is designed to develop our expertise in the art and the science, because importantly, there is a science to implementation that we all need to learn. So no one is better suited to helping us build that expertise than my friend and colleague, Dr. Marcy Wingate, who is our own in-house expert in implementation science. She directs the Evaluation Sciences Unit in the Division of Primary Care and Population Health in the School of Medicine. She's PhD and master's trained in epidemiology and in biostats. She's got 20 plus years experience in healthcare related research, including more than 6 years at Stanford. Her Evaluative Sciences Unit is a team of implementation scientists with broad expertise, including study design, quantitative and qualitative analysis, and dissemination, and they partner with people like you to evaluate improvement efforts at Stanford. So if you've got one going on, she said that I could plug that you should contact her or members of her team if you're interested in that kind of partnership. I think, Marcy, the plan today is for Dr. Wingate to talk about practical real-life examples of applying implementation science outcomes to quality improvement endeavors. I believe this is intended to be relatively casual, where questions are welcome throughout. Lisa Freeman and I will both monitor the chat. If you'd like to put questions there, you can also, I think, wave wildly, and we will try, or raise your hand and the participants do wave wildly, or when Marcy takes a breath, just interject. So Marcy, with that, thank you so much for doing this today. Over to you.
Well, thank you so much, Sarah, for that very, very kind intro. And I'm super happy to be here. And I really appreciate all of you coming to my talk today. And I just want to say, although I have called these practical examples, it doesn't mean they're easy. And so my goal, though, is that these examples are helpful for you in your own work by giving you ideas of how to approach your improvement and evaluations efforts in a way that will enhance what you're already doing, because I know all of you are doing a lot towards improving delivery of care. Oops. Now, why am I not being able to go forward? There we go. Okay. So as Sarah said, I would like this to be interactive, so I will be stopping multiple times for questions. And even after my brief introduction, I'll stop, and then I'll stop throughout the examples I give. Lastly, I just want to say I originally planned to present 3 examples, but I realized as I was getting into this that I would only do I could only have time to do 2. So I think someone is on. Could you just, everyone, make sure you're muted? I hear some scuffling. So before I discuss outcomes, I want to briefly just give some background on implementation science as it applies to healthcare. And this reiterates some of what Sarah said in the beginning. There are a couple definitions of implementation science you can find, but I wanted to give one that was specific to healthcare so it really resonates better with you. And the healthcare is not usually part of the typical definition. So I came up with the one that's on the slide, which is implementation science as applied to healthcare is the systematic development and application to methods that enable implementers to understand how, why, and for whom the different strategies are successful or not in implementing the change into healthcare practices. And the reason I'm spending time on this is because my point is I want to say it's practical and it's scientific. And I'm pressing this point because we frequently run into potential partners who are a bit resistant to some of the outcomes that we're talking about and focusing on, because there's a feeling that they're too soft and it's not real science or real research or real improvement, and maybe it can't be published. But I hope by the end of this talk, if you're thinking that way, that you will change your mind. So what are the implementation science outcomes and why do we care about them? Well, generally, the goal of a QI project is to implement an intervention that will be effective in addressing whatever problem it is you want to solve. But effectiveness is a function of 2 key factors. The first is the inherent efficacy of the intervention, which, you know, if you're lucky, maybe you have an intervention that has been assessed in a clinical trial and you feel confident that it's going to work. But if you don't actually know the degree to which the intervention was implemented and it's not effective, you won't actually know why it wasn't effective. So implementation outcomes measure this latter piece, the degree to which the intervention was implemented. They provide insight as to why it may or may not have been implemented as planned, and how or why there were differences in that implementation. So what are the implementation outcomes? There's a variety of ones that were used, but the ones I'm going to show you are slightly modified from the Proctor et al. Manuscript noted below. So acceptability measures which aspects were the clinic faculty or staff willing to implement, what were the barriers and facilitators that they had to implementing the plan, and their attitudes. Adoption is really just how much of the model was actually implemented. What was the uptake? This is often quantitative, but may be qualitative components as well. Appropriateness and fit is really measuring how or whether the intervention fits the context of it. And in in healthcare, it may be that it's appropriate for some patients, but not others. Maybe certain clinics it's appropriate, but not others, etc. And so this allows us to assess those contexts and also assess why it may not be so great in a particular context. Adaptation and fidelity assess whether the model was implemented as planned. And fidelity is generally important if you, again, you're implementing an intervention that has some proven efficacy around it. And so you have some incentive to make sure that you really want to, you don't want to change it. But on the flip side, because every clinic setting is unique in some way, you might already plan that, okay, you're going to have to adapt it in some way, and you want to make sure you you measure that as well. Some people split these into two different things, but I think it's helpful to just kind of put them together in the same, so the measures kind of balance each other, if you will. Feasibility, which aspects were possible or not to implement. This kind of is complementary, but maybe overlap a little bit with some of the adaptation and fidelities. And then sustainability, can you continue this over time? What's required to do so? I'd like to put an extra plug for sustainability because it's often really not measured at all. Or if it is, not to the measurement doesn't go on after the initial implementation, and it's actually useful to continue, because what happened during the official project period, if it went well, you want to make sure you have some measures going on in the future to ensure it continued. Now, the last thing I would like to talk about are just driving principles and characteristics that my team considers essential components of our work. And I bring them up because I encourage you to think of them in your work as well. And the first is that we conduct our evaluation in a truly partnered way. And what does that mean? It means we work closely with funders, clinical leads, the clinic staff, the quality improvement teams, whoever the primary stakeholders are, to ensure that we understand what they are trying to achieve and that we're in sync with them. And we also have a goal of helping whoever we're partnering with in developing, to really facilitate their development of a learning healthcare system through our process of working with them. And I know that's a goal of everyone here, and it's easy to say that you have a learning healthcare system, but if you're not really understanding and paying attention and measuring to what works and what doesn't work and why, and then adapting, then it's not, and following up with the outcomes, then it's not really a learning healthcare system. So we also, the way we facilitate the learning healthcare system is by building in quick feedback loops to implementers and leaders. And this is also something that I see quality improvement teams do that a lot as well. So I would say some of the principles are complementary to what the QI leadership at SHC is doing. And the way we're able to provide quick feedback is because we use mixed methods. And again, the qualitative methods and interviewing, observing things that are going around in clinic really help to do that. So I'm just going to pause there real quick for questions. I can't see anyone, so I don't know if there's any questions.
There haven't been any questions posted yet, Marcy, but I'll kick you off with one, which is, does ESU offer a range of services for people who want to partner with you, or is it, is there one sort of preferred approach in working with you as a group?
We work with a wide variety of projects in terms of sizes, complexity, and number of people involved, shall I say. So typically a partnership starts by just reaching out to me or one of the other people on my team, and just having a consultation and discussion about what it is. And generally, so we can do ad hoc consultations, or we can take on medium or large projects. Occasionally, just one person on my team works on a project, but usually it's at least 3 or 4.
Anybody else have a question? I don't see any in chat.
Okay, I will move on. That's fine. So the first example is the evaluation we did with neurology last spring on their rollout of video visits. And I thought, at first I was going to put this as the last example, and then because the pandemic has gotten worse, I flipped it, and I thought this actually might be the most salient example for most of you, because video visits are maybe becoming even more important, and they're not likely to go away. A lot of departments are really thinking about how can we sustain these, and how can we, who are the patients for whom these types of visits are appropriate, and what's the best way to continue. So I thought it would be useful to just go over the work we did here, both because the methods could be applied to any other kind of project, but there's also, I think, some nice learnings from this study for others who are thinking about video visits. And just want to point out that we have 2 publications from this work, and another one, another paper just got accepted and will be published soon. So first off, what are the video visit implementation outcomes that we looked at? The first was adoption, and we used scheduling data for adoption. So the analysis I'll show you in a couple minutes could be done by any department, and I actually think would be really interesting and useful for administrators and managers to compare and contrast across the different clinics or departments, using the same way we did to really help them think about strategy for continuing video visits in the future. So the other outcomes we focused on were acceptability and appropriateness, because there was a strong interest in figuring out what worked best for whom and why. And for both of these outcomes, we used a combination of interviews and surveys. And the interviews included interviews with both physicians and patients. And I think that's another example or point I'd like to really encourage people to think about, how they can include patients as part of the people who they seek information from for how things are working. So because, so the first results I'll show here are the adoption. And because the pandemic was, because of the pandemic, we expected that the total number of patient visits that would occur in 2020, when we were looking at the data, and I should back up and just say, we did this project in about 3 months, from March through June, maybe that's 4 months, but the data we used was about a 3-month period. And so a lot was done in a pretty short amount of time. But one could measure adoption for video visits just by saying, okay, how many video visits were done in the time period? But we wanted to have a more thoughtful approach. And because the pandemic, we expected the number of visits, the total number of visits in the same time period of 2020 to be less than they were in 2019. And because there was some interest in understanding how many visits, how many potential patient visits were actually being lost by this pandemic, we decided to use the 2019 as our denominator, if you will. So in these graphs, the circles represent 100%. It's the total number of visits in 2019. And so we looked at all patient visits, and then there was a lot of interest in understanding whether patterns of care for new patient visits differed from return patient visits. So in these graphs, the light color shows the percentage of patient visits that occurred in 2019 that did not in 2020. So 21% of the potential visits, if you will, for 2020 were lost. But 72%, the light blue, can you guys see my arrow that I'm using or no?
Yes, we can.
Yes.
Okay, great. Yeah, so this light blue area shows that 72% of the potential visits occurred via video in 2020, and there were only 7% were in person. And you can see across here that the new patient visits had a greater loss of potential than the return patient visits. I just want to pause there a minute. I know some people have, I feel like these are intuitive, but some people I know have had some problems understanding these. So I just want to make sure everyone understands these graphs and why we did it that way. Okay.
I don't see a question. I don't see a question about the graphs, Marcy, but I did want to mention, and maybe you can come back to this when it's useful for you. But there was a question in the chat. Karen Ellis asked, how does scalability fit into implementation science and implementation outcomes? Maybe you can talk about its relationship to the sustainability metric that you had described earlier.
Yeah, scaling and sustaining are definitely related, but they are a little bit different. And I appreciate that question. I didn't put it as an outcome, but technically it is absolutely an outcome. We haven't actually done any projects that looked at scaling. I would actually love to do that because I think it is a super interesting issue, and how you implement in a small defined context, which is how QI projects usually start, and how you scale them. Definitely you have to adapt a lot of times for things. Just yesterday I was in a meeting where someone was saying, what I've personally done to date has worked well, which is going around and making personal relationships with people to get buy-in, but it would be great to think about how to scale that and make that a non-person dependent process. So the thought we had in that meeting was having some kind of educational intervention that could be developed and then more broadly implemented. So that's an example of scalability. I don't know if
I just want to.
Yeah.
Will make one comment about it, Marcy, if I can,
Yeah.
in response to Karen. I think there's a big difference between an intervention where you intend for it to scale and what it would look like to think about assessing scalability from the beginning, in terms of how much input you get from the places to which you would scale and how applicable it would be in those other settings, versus a intervention that you implement in one setting, decide, oh, it's really working out very well here, why don't we take it somewhere else? It would be a very different way. There's two really different challenges that you're dealing with. So scalability is a really good question. Thinking about it in advance is highly recommended if it's something that you think might have legs, like the one we're talking about right now.
Yeah, thanks for that. And I would just say that it's the same for sustainability. If you're implementing something that you're hoping to sustain, you need to pay attention to the sustainability issues that you might have and learn as much about the issues you might have around sustainability the first time out, and not wait till later to try to think about it. Okay, so back to this example. So one of the ways that we addressed adoption, all patient visits, and then new versus return. The other way we sliced it is neurology has, I think, 10 or 11 different subspecialties, and they vary a lot by things like how the importance of the physical exam and the mental and physical condition of the patients. And so there was a very big interest in understanding how the patterns of video visits differed across the subspecialties, and as well as with respect to the new and return patient visits. And I don't expect you to read all the detail in here, but you can tell clearly from these graphs that there was a lot of variation in terms of the success with new patient visits. Here, headache had, I actually think, if I'm remembering correctly, headache had more new patient visits in 2020 than they did for 2019. And so we couldn't really indicate that because these are representing 100% of 2019. But and headache also clearly was very successful in not losing any potential visits for the return, as was memory. But some of the others, like epilepsy and movement disorders and neuromuscular, had much less success. And not surprising, because when we get into acceptability and appropriateness, that kind of explains why. So before I get into the actual data, I wanted to just talk a little bit about how we actually assessed acceptability and appropriateness. I mentioned we use surveys and interviews. The surveys, ideally, we've gotten a lot of questions about how to make a survey or how to choose a survey, and generally it's always best to use a survey that's already been validated and developed. But there were no such surveys in this situation. So we co-developed it with the ESU team and the neurology clinical partners. And we spent, we had a lot of discussions around how to make it short, but really get all the desired information we wanted, like they needed, to move forward around acceptability, which basically barriers and facilitators, and appropriateness. And appropriateness, again, is really kind of the clinical fit. So which clinical scenarios, patients, and visits were most or least appropriate for video versus in person. And so the surveys ended up having a series of questions asking about things like the physical exam for new patient visit can be done as well in an in-person visit as a video visit. And then the same question for a return patient visit. So we were able to assess kind of difference between the clinical perspective of, you know, how well they were able to do the new and return visit on multiple factors. And then similarly, the interview guides were then developed to complement the survey data for both the acceptability and appropriateness. Again, thinking about the sustainability, because if they can understand the clinical scenarios and the patients who are benefiting most or least, they can think about how to sustain them in the future. So this table here shows acceptability, and what we see here is in the survey that was sent to the physicians, which I think we had about 70 or 80% response rate, so we had a very good response. One of the questions was, what are the 3 factors that are the biggest barriers for you? And they identified technology, engaging learners, which I mean basically the residents and fellows, because they were not able to participate in the video visits alongside them, at least initially. That was a very difficult thing. And then the relationship is their ability to develop rapport and trust with the patients. And I have an asterisk here because this actually flips on the next slide. But we also had a question that was, what are the top 3 things that you're excited about for video visits? And those were patient access, the patient time cost, you know, their travel, and then physicians being able to work outside the clinic, so work from their home, were the top 3. And so if we look across this and see how it compares to the clinician interviews and the patient interviews, we see that there is some variation. Interestingly, when we talked to physicians, they didn't actually, the engaging learners didn't pop out as a key thing, a key issue, even though it was for the survey. And although the survey and the clinician interviews identified development of relationship with patient as an issue, patients didn't. And I thought that's extremely interesting. And when clinicians were interviewed, they also identified language as a potential barrier. But it didn't pop up for patients or in the survey. Now, we only interviewed English-speaking patients, so it's not surprising that it didn't pop up there. But the main, one of the main reasons I wanted to show the data was like this, was to just show how there is variation. There's consistency for some things, but also some variation in terms of what came up as important, and what not only the issues that came up important when you collected the data in 3 different ways, but also that the responses were not necessarily consistent. And this is again why it's really important to think about how to collect data in multiple ways, but also include multiple stakeholders whenever possible. So the appropriateness is similar. And what we did for appropriateness is we specifically asked questions around quality of care, the visit length, efficiency, the patient-physician rapport, ease of patient history taking, and ease of the physical exam, because these 5 issues were kind of these 5 factors were what the neurologists said were really, really important for them to think about for both short-term and long-term sustainability. And then continuity of care and MD well-being just were things that popped out either in the survey or from the clinician interviews as well. And so here for quality of care, there was mixed, and this is primarily because of the new versus return patient visits. There was a big difference in terms of the quality of care seen there. Although the clinician interviews were fairly positive, as were the patient. And same with the visit length efficiency was mixed in the surveys and the clinician interviews. And this was interesting. It's partly because of technology, but partly because when we did the interviews, the issues that came out for sometimes that were negative around the efficiency and visit length were around workflows. And they felt like sometimes they were having to wait because they couldn't just start the visit earlier if, for instance, one of their visits stopped. But from the patient's perspective, they were extremely positive around all things around the visit length and the efficiency. And again, no problem with the relationship. And so coming back to the relationship, in the survey, there were 2 ways we measured this relationship question. So as I said previously, it was one of the top 3 issues that came up that was marked that people said were a problem. But when we had a question asking about the equivalency of relationship and rapport building between physicians and providers in new visits for video versus in person, it was, I think 60% said it's the same, and around 90% said it was the same for the for a return patient visit. So there's some mismatch here. This was based on what they had experienced. So it may be that the negative concern around relationship building was more and that anticipated than it actually happened. But again, this is, I thought this was very interesting. The physical exam unanimously was considered to be the biggest issue for, from all ways we collected the data, but patient history was considered to be really good. So the last thing, even though I didn't have sustainability as an outcome, I wanted to mention it because we did look at it a little bit, and kind of the summary of the work was that really need to figure out how to address the physical exam limitations. Maybe it just means you don't have video visits for physical exams. The patient's technological capacity needs to be taken into account. The visit type, new or return, needs to be taken into account, and the patient preference. And the thing is, the feeling was that, okay, you need to assess these prior to scheduling the visit. But the problem is that there was a feeling that triage and pre-visit screening to assess these things is overly burdensome. So to me, this says that the key thing for sustainability is figuring out how to do this triage pre-visit screening, how to build that into the workflow so it's not overly burdensome. And I'm going to stop there. Maybe just let us see each other for a couple minutes. Any questions, comments, thoughts about that?
I don't see any in the chat at the moment, but I'll kick you off with one, Marcy, which is, you know, first of all, that example was really terrific and it helped us see the application of those outcomes, but you didn't use them all. And so, you know, you started out by saying that this implementation science work was a combination of the practical and the scientific. And I'm wondering if you can talk about the art of selecting the, you know, how do you know which of these outcome measures, or do you strive to do them all each time as you take on a new project?
So I don't think I've ever had a project where we looked at all of them. And I think this is where the practical and pragmatic side comes in. And so I think the way we approach that is really thinking, we encourage people to think about what are the most important things they want to learn. Like, how would they know whether they implemented what they wanted to? And again, going back to the sustainability or scalability, do they expect that they will do that? And if so, what information do they need to know to even get to that next step? So there's kind of, we think about it, we encourage people to think about both kind of short term. There's always going to be facilitators and barriers. And so let's try to get an understanding of those as early on as possible. So to help inform whether tweaks to the implementation strategy or intervention itself will have to be made. And then as we might kind of grow the implementation outcomes as we go along, depending on the duration of the project. Some of the projects are multiple year, and so then you have a lot more time for planning it out. But in this case, it was 3 months, so we had to just be boom, 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 and really make decisions quickly and decisively, and go towards what the clinic team felt was most important for them to know.
Thank you for that.
Go ahead, Sarah, sorry.
I was just going to call, I was going to, I don't know if you have a question. I did have a couple kind of in queue here.
Yeah, I was just going to say, Marcy, good presentations, of course, and great presentation. But one of the things that we use in trying to decide which of the implementation outcomes are going to be most relevant is by looking at other similar interventions and see which implementation outcomes have proven to be the most relevant or most difficult to achieve for those similar interventions. And there are many, many interventions that have implementation similarities without content, meaning clinical content similarities.
Yeah, good point. Okay, and just turning to the chat, Olga asked a question which was about, highlighting the fact that you were talking mostly about data from interviews and surveys. The question is, have you looked at any clinical outcomes like number of ED visits from patients video versus in-person visits? And that's a question obviously specific to this specific intervention, but maybe you can also speak to the way those qualitative outcomes interact with more quantitative approaches.
Yeah, so things like ED visits tend to be effectiveness outcomes. And so there's a lot of different types of study designs. And so one is where the focus is just knowing, were we able to implement this intervention? And that's where, pretty much you're only using implementation outcomes. Sometimes you're interested in understanding a combination of both the implementation as well as the effectiveness. And so in this particular study, we did not look at ER outcomes, but that is a great idea for something that could have been looked at to see if, for instance, people who had video visits were more likely to end up in the ED for emergency than those who came in for in-person. So again, because we were not looking at effectiveness per se, we didn't, but that's absolutely something that could be looked at. Now, one thing I want to just caution people, ER visits and hospitalizations and mortality it seems like are always kind of the top outcomes on people's mind. But unless you have a long enough study, you're not going to have any power to assess any difference. And so that's another reason why I really encourage people to look at the issues they have around implementation before jumping to kind of the traditional outcomes of things like ER visits. the studies that have outcomes of things like ER visits, length of stay, etc., usually are multiple year, sometimes even like 5 years to have enough events to see a difference.
And then let me invite Dave Larson, who has a question.
Great, thanks, Sarah. Thank you, Marcy, for that really excellent presentation. A question I have, maybe kind of bigger picture. I often see, we especially maybe at Stanford, see one end of implementation science, and that is where we do the intervention and the assessment and publication, and it goes out into the world. So that's the push, as I see it. What's the pull, and how does this end up getting utilized? How do we use implementation science to guide our decision making in individual projects, in broader strategy? How do other organizations use it? And to what degree does it just kind of go out into the academic literature and just kind of park there? Or how does it influence care, influence design, and how can we make it so it does that more?
So I'm gonna take a shot at this, and then I invite other people to add to it. But to me, I see this as a fundamental principle of being a learning healthcare system. And as I said earlier, like just because an organization does a bunch of improvement projects, it doesn't mean they're actually a learning healthcare system. To be a learning healthcare system, you have to think about those scalability and sustainability issues. You have to think about, is it worth continuing this or not, rather than seeing it as just like a quick 3-month or 1-year project. Really, and I think the VA has some pretty nice examples, I think, of how they have successfully developed at least parts of the VA into a learning healthcare system. But it requires a lot of work and effort and alignment of priorities, I think.
And can I follow up even more, maybe even more specifically? Let's say, for example, the video visits example. Did we do a literature search before we started implementing video visits to find out, and I don't even know who we is. Right now we're speaking in the abstract, but like, I don't know, did Quinn McKenna do a literature search, or who should be in the organization, right? And like, I'm trying to think very practically, like how, I know we publish it, and we, whoever the we is, as an organization, maybe learn over time, but we're putting it in the literature. So how does it, who's the person, who's the vehicle that gets actually, it translates into it making an impact, both others to us and us to others?
Well, I'm personally a fan of top down and bottom up, and having both of those happen together. And I think this is actually a perfect example. We have so many learnings from this particular project. I think it would be a shame if the organization didn't do some follow-up and did more analyses, as I said at the beginning, across departments to see like what happened across departments with respect to video visits, and just looking at the adoption in the way that we did and comparing across. I think there would be tremendous learning and, around that. I know, Steve, I see you unmuted, so I'm guessing you are wanting to say something too.
I wasn't, but I will. How's that? So I think there are a lot of different models for this. So for instance, let me just say one thing first. So there's the interventional development and the evaluation once the interventional development has at least been underway. So you said, do we do a literature review before we figured out what to do with video visits? So from the point of view of the evaluation sciences unit, by the time the project gets to us, most of the time, the people who are wanting to do a change have already kind of settled on something, and we will often help them by doing a literature review. But at that point, I think it's really just often a small deflection in course that the literature review is capable of. If instead we wanted to have more of a ground up, as Marcy puts it, look at what are the potential interventions that we could do. That's not something so far that in the evaluation sciences unit we have always been able to do. That is something that as health services researchers we routinely do before we apply for money to try and test an intervention, as I'm sure many of the people on the call would confirm. So in some other organizations, there are people who are constitutively paid to do exactly that. So in Mayo, I think there's a shop that does it. Kaiser, there's supposed to be a shop, although I don't think it functions all that well. We heard from NYU, I think it was last year she came. So I would love it, for instance, if this group, meaning this center, was one of the places that people could go to try and do that first step of interventional development. I think that there's a lot of room for us to do that together.
Yeah, thank you. It just seems if we're going to, you know, if there's a science to implementation, then we should be doing that before we implement, right? Not after we've started implementing and now we want to study it. So I know that I'm preaching to the choir here. Maybe
yes, there are definitely a lot of choir members on this call.
Yes, yeah, but I'm saying it to myself and to all of us. Sarah,
David, I would push back just a little bit to say that, you know, certainly I agree it would be, you know, irresponsible, wasteful not to look at what others have learned from trying to implement interventions like of the sort that you are considering. Absolutely. You know, the whole point is to learn as best we can. And at the same time, there is the need to recognize that implementing here may be different. So finding that balance is appropriate too. You don't want to do so much, you know, analysis that you are stuck and not moving forward. So I think it is important to find the balance between them. But certainly you don't want to skip that first step. I agree.
Yeah, and if I were seeing, you know, having seen the projects that we oversee, if I thought that we were doing too much analysis, then I probably would have had a different comment. But I think we're probably erring on the side of not enough at this point. But yeah, your point is excellent, Sarah. It's really well taken. But it's a reminder to me. It's like, you know, so many people have already learned so much. You know, especially if we're implementing something big that others have already done. Let's go out to the literature, and if we don't know how to do it, then call up Marcy or call up Steve or call up any of us, and we'll get people connected to figure out where to go in the literature.
Well,
Absolutely.
and for video visits, I would say call up Gloria Huang.
Marcy, we have about 5 minutes. I know you had other examples, and I'm not sure we're going to give you the opportunity to get to those. But if you had kind of concluding advice for the group, I think that's probably where we're at.
Yeah, I actually was guessing that I would only get through one example. I
hope you'll post your slides. When you post your slides, I hope you'll include them all, and then people can refer to them.
Yeah, I'd be happy to. The other example, just quickly, was from the Cancer Center, which is a much longer term project, but it was an intervention that was done over 2 years, but the outcomes were that I focused on were the same. But I encourage you to look and see kind of different ways we looked at the data and collected the data for those. Oops. Hold on. I accidentally, I think my key takeaway is really partnership, and really consider multi-level perspectives when you're doing this work. And it's so often in healthcare that one group of stakeholders is super excited about something that impacts 5 other groups of stakeholders, and they just don't think about it. And so I encourage you not to be myopic and really think broadly. And the clinical teams, you know, remember you have staff, you've got front desk receptionists, you've got nurses, and don't forget the patients. You know, so often great intent to improve healthcare for patients in some way is sought, and then no one talks to the patients. And it's really a lost opportunity. So I just encourage you use the medical students or fellows can help.
Yeah, if you don't, like maybe take an allergy pill and see if that helps.
Oops, Rochelle, I think you need to mute. So Marcy, with that, thank you so much for being here. Among the partners, reach out to ESU to see about partnering with them, affiliate with the Center for Improvement and partner with all of us on this journey. Monique Bouvier put another resource, Lane Library reference for people who specifically are interested in literature review. Wanted to call your attention to that. Dr. Wingett, thank you for sharing your expertise today. That was wonderful.
Thank you all. All right, hope to see you again soon.
Thank you.